Okay, good. Sorry, hi, I'm Christian Berkley, co-director of the program in clinical ethics here as part of the Center for Bioethics and Social Sciences in Medicine. Welcome to Bioethics Grand Rounds. I'm really excited to welcome Scott Grant, who's been a friend of mine for a very long time, since he was a medical student. And he's now a senior fellow at the McLean Center for Medical Ethics at the University of Chicago. He's also the endocrine surgery fellow there this year. Scott actually is no stranger to Michigan. He grew up for the first 5 years of his life in Fraser, Michigan, and then lived in Bloomfield Hills until he was 18 when he went off to Princeton. Then he had an illustrious career there, and then went off to the combined medical school program between Brown and Dartmouth, graduating with his MD from Dartmouth. He then spent some time at the University of Pennsylvania, where he got a master's degree in bioethics. He did his general surgery residency at Rutgers, Robert Wood Johnson Medical School, and then also during that time completed the Surgical Ethics Fellowship, the one and only that exists in the world that I know of, at the University of Chicago. He then returned back to New Jersey to finish his surgery residency, and is now again back at the University of Chicago, where he's the senior fellow. Scott is welcome back to Michigan, and he's going to talk to us about dealing with complications and surgical futility.
Well, as Christian said, it's my pleasure to be here, and it's great to be back in Michigan. So I don't have any disclosures in the traditional sense. Unfortunately, they don't usually pay much for ethics work. But I am the Resident Associate Society Liaison to the American College of Surgeons Ethics Committee, on the Association for Academic Surgery Ethics Committee, and also helped co-found and co-lead the American Society for Bioethics and Humanities Surgical Ethics Affinity Group. But none of the opinions that I'm going to be sharing with you are related to those entities. So I have a little bit of history working on surgical futility. This was a book chapter that I co-authored on futility in the care of the perioperative patient in ethical issues in anesthesiology and surgery. And I also wrote an article on futility in the care of surgical patients, ethical dilemmas in the World Journal of Surgery just 3 years ago. But in terms of how I came to know Christian, I was a third-year medical student at Brown, was already accepted into the master's program at University of Pennsylvania in bioethics, and knew I wanted to go into surgery. And John Banja, who's a professor of ethics at Emory, was giving a talk on this book that he'd written in 2005, Medical Errors and Medical Narcissism. And I went up to him afterwards and sort of expressed my interest, and he said, "There's this person that you have to meet, Christian Berkley." And so I then wrote him an email, and you can see this is from May of 2008, telling him sort of my history, and he's like, "I'm glad to hear that there are med students interested in surgical ethics. It's an important field. We're a small group of folks, so it's easy to get to know everybody." And the first person that he recommended that I get to know is Peter Angelos, who's currently my program director in my endocrine surgery fellowship, and also is sort of my mentor during my time at the McLean Center, both then and now. So this is a quick outline of what I hope to cover today, and I realize there's a lot of topics, but I want to discuss how surgical ethics is distinct from medical ethics, how surgery is unique in that honoring the principle of non-maleficence is difficult because we harm before we heal, that complications in surgery are common, but some, or even many, you could say, are preventable. Discuss some strategies to assess perioperative risk and hopefully thus reduce it by patient selection. We'll discuss blame and surgeon confidence, the emotional phases of responding to complications, the spikes protocol for delivering bad news. I'll kind of briefly touch on some human error theory and the Swiss cheese model with regards to human error, and how sentinel events and root cause analyses might be important in terms of thinking about surgical ethics topics. And then I'll discuss sort of the era of surgeon-specific transparency that we're in, and the surgeon scorecard. Finally, I'll discuss a little bit disclosure and apology after adverse events and complications, and move into futility, both definitions and procedural approaches. So I think a good place to start on a surgical ethics talk is I was with Charles Bosk, who was a sociologist and spent a year and a half among surgeons, basically studying how attending surgeons dealt with error among their trainees. And He was at an unnamed institution that I'll disclose to you is actually the University of Chicago, trying to figure out what errors were forgivable and what errors were not. And he said that technical errors, or errors of technique in surgery, are forgivable, but normative errors, or errors of character and honesty, are not forgivable. I'm just going to read to you this quote, which I think illustrates how surgeons are different in terms of the way they think about ethics. The specific nature of surgical treatment links the action of the physician and the response of the patient more intimately than in other areas of medicine. In many branches of internal medicine, the physician's interventions are relatively nonspecific. This fact allows internists to attribute failure to the inevitable pathophysiology of the disease process, rather than to the nature of treatment itself. Of all physicians, the surgeon's interventions are most visible and his therapeutic expectations are most specific. These features intimately link the surgeon's action to the patient's condition. And one more quote from Charles Bosc. When the patient of an internist dies, the natural question his colleagues ask is, what happened? When the patient of a surgeon dies, his colleagues ask, what did you do? By the nature of his craft and his beliefs about it, the surgeon is more accountable than other physicians, and he also has much more to account for. Of course, this is not all to say that every time a surgical patient dies, the surgeon is at fault, only that it's much harder for him to claim that he had no hand in it than it is for other colleagues. And we as surgeons, I think, are called upon to answer that question every week at M&M and take personal responsibility. Healthcare professionals in the perioperative setting feel a special responsibility for what happens to patients in the operating room. There was a piece in JAMA by Robert Walker in which he wrote, since surgery, more than any other activity, involves physicians doing things to patients, any death associated with surgery quickly raises the suspicion of human error and the specter of malpractice. And these aren't sort of new sentiments. Dr. René LaRouche, who wrote a text on the philosophy of surgery in 1951 and was a French surgeon who lived from the late 1800s to the 1950s. For those who are in vascular surgery or familiar with it, LaRouche syndrome, or aortoiliac occlusive disease, is named after him. He also trained the famous surgeon Michael DeBakey. He wrote, every surgeon carries within himself a small cemetery where from time to time he goes to pray, a place of bitterness and regret where he must look for an explanation for his failures. When I was speaking with my wife about this talk, who's an emergency room nurse, I mentioned this idea of every surgeon having a small cemetery. And although she's no stranger to patients dying, she's like, I don't have a small cemetery. And I think that's, again, illustrative of the fact that surgeons feel this special responsibility. Dr. Henry Marsh is a British neurosurgeon who was born in 1950 and has recently gained international acclaim and fame for this best-selling memoir, Do No Harm, Stories of Life, Death, and Brain Surgery. And he wrote, knowing when not to operate is just as important as knowing when to operate, and is a more difficult skill to acquire. And very early in my own surgical training, I learned the aphorism, first you learn how to operate, then you learn when to operate, and finally, and probably most importantly, you learn when not to operate. So no ethics talk would be complete without mentioning Epocrates and his famous principle primum non nocere, or first do no harm, which actually wasn't part of the Hippocratic Oath, was from his other writings in Epidemics 1. But as I mentioned in my outline, surgery harms before it heals, and non-maleficence in surgery thus requires accurately determining the risk-benefit ratio and operating only when it's favorable. So dealing with surgical complications is a topic that I think every surgeon can relate to, but not much had been written on it until relatively recently. The January 2014 Bulletin of the American College of Surgeons had sort of a special section with essays written by residents on this topic. So in terms of dealing with complications, first, they're common. They lurk in every decision or action or inaction that we take. Second, surgeons face complications in a more overt way than their medical colleagues, as I think Bosc nicely illustrated. Next, every surgeon has complications. My general surgery program director, Stanley Truskin, used to say there's only two types of surgeons who don't have complications: surgeons that don't operate and surgeons that lie. I think that we need to recognize that whether complications occur is not entirely within our control. You know, there are certainly patient factors such as their comorbidities, whether they're compliant, and other unique factors, maybe even the time of day of when we're doing an operation. Martin Khari is a pancreatic surgeon at Johns Hopkins, where he also teaches health policy at the Bloomberg School of Public Health, and is a New York Times bestselling author and advocate for transparency, and has published extensively on safety and teamwork culture. He also worked with Dr. Atul Gawande on the World Health Organization's surgical safety checklist. And he wrote this book, Unaccountable, and he also recently published an article in the British Medical Journal that medical error is the third leading cause of death in the US. Basically, he suggested that if we, on death certificates, wrote medical error as one of the possible causes of death as opposed to the traditional cancer or heart disease, that it would come in third with 251,000 deaths. And whether or not you agree with his methodology and conclusion, I think we can all acknowledge that medical error is a ubiquitous phenomenon. So in terms of although surgeons are eager to operate because a chance to cut is a chance to cure, surgical judgment is key in preventing complications, and that starts with your preoperative decision making. So the best way to avoid complications, I think, is to prevent them, and you do this via patient selection. So there's a famous surgical expression that to a hammer, everything is a nail. But if as a surgeon you operate on every patient without weighing the risks, you'll regret it. There's a lot of ways that you can preoperatively optimize your patient, whether it be improving their nutritional status, changing their medications for their hypertension or heart disease, giving them inhalers. There's also been work recently on frailty and improving their functional status, getting them strong for surgery. There's sort of a debate about safety versus speed in surgery, and some surgeons say to residents, learn to be fast now, you can learn to be good later. I take a different view. I'm more of the view that you should measure twice and cut once, double check your work at critical points in the operation, because once is fast. Or in other words, it's faster to do one good operation that has no complications than one quick operation with complications you'll be managing for days or weeks, or that might even require a return trip to the operating room. Finally, don't let pride put your patient in danger. It's better to abort a procedure than to try to accomplish the original goal. In terms of assessing a patient's preoperative risk, the American College of Surgeons developed a national surgical quality improvement program that led to the development of a surgical risk calculator. It's freely available at the website below, although it does come with this disclaimer. And obviously, surgical judgment is still paramount. It has a lot of variables, although they're very quick to enter, things like what procedure, and they have specific CPT codes for this, the age, sex, functional status, whether the surgery is an emergency, the ASA or anesthesia class of the patient, the wound class, steroid use, whether the patient has ascites or fluid in the abdomen, whether they have sepsis, if they're on a ventilator, have disseminated cancer, diabetes, hypertension, previous cardiac events, congestive heart failure, whether they're smoking, have COPD, are on dialysis, or have acute kidney issues, and also their body mass index. It then gives you a percentage likelihood of serious complications, any complication, pneumonia, cardiac complications, surgical site infections, blood clots, urinary tract infections, kidney failure, return to the operating room, death, and also whether they're likely to be discharged to a nursing or rehab facility and how long they're likely to spend in the hospital. The NISQIP risk calculator, although a very helpful tool, is no substitute for good judgment. And unfortunately, good judgment comes from experience, but experience comes from bad judgment. So surgical complications will continue to occur. So I'm going to talk to you briefly about the ABCs of surgical complications, which are assign, blame, and condemn. especially anesthesia and those lower in the hierarchy. And just so you know, Gomer Blog is a medical satire website, kind of like The Onion for doctors. And they had an article a few years ago, When in Doubt, Blame Anesthesia. For the surgeons in the audience, the fact that we blame anesthesia is just common sense. But for the non-surgeons, just so you know, this is a joke. We know that it's not always anesthesia's fault. So I'll start this slide by saying, first, I know that Tom Brady went to the University of Michigan, and that it's undoubtedly why the Patriots won. But if you're the Falcons, that's not an adequate excuse. The New England Patriots came back from a 25-point deficit to complete the greatest comeback in Super Bowl history, winning 34-28 in overtime against the Atlanta Falcons. When asked to comment, the Falcons coach, Dan Quinn, had only one explanation for the collapse. It's anesthesia's fault. United Airlines actually felt the same way. After 2 days of unsatisfying answers from United Airlines regarding the violent extrication of a passenger from its Chicago to Louisville flight, CEO Oscar Muniz has sent a new message to his employees: it's never too late to do the right thing. Let's blame anesthesia. In case it's not obvious enough to just blame anesthesia, there's also a flow chart that helps you know who to blame. And anesthesia appears on this chart twice, but also the OR nurse, the resident, the patient, a radiology interpretation. And I think that the point of me saying all of this is that assigning blame and condemnation, even of anesthesia, is not the answer to our complications. As Charles Bosk noted, final responsibility lies with the attending surgeon. And I think that this next article perhaps captures the essence and ethos of the surgeon better than almost anything else that I've read except maybe Bosk. Whenever something bad happens, stay calm and say, I assume full responsibility and it won't happen again. Acting defensive or blaming someone else, whether it's justified or not, is a rookie mistake in surgery. The article details the story of a kidney transplant patient's blood tests that went missing. The resident thinks about telling the full story. She ordered the blood tests, the phlebotomist drew the blood and sent it to the lab, and then somehow the tube went missing. But then instead, the resident says, I assume full responsibility, it won't happen again, draws the blood herself, and hand delivers it to the lab, then waits for the results to get printed. After repeating the mantra, I assume full responsibility, so many times, she internalized it. She really believed it. And when something went wrong with one of her patients, whether it was the patient's fault, her fault, or someone else's fault, it was always her responsibility. When someone trusts you with their life, the buck stops with you. Accountability is at the core of what it means to be a surgeon. In order to really be responsible for our mistakes, we must own up to them and personally commit to preventing them in the future. So I think that we could all agree that surgeons need confidence. There's a famous expression, surgeons, sometimes wrong, but never in doubt. There's also a famous surgical expression about learning procedures, see one, do one, teach one. But I think if we take this approach too blindly, it'll be see one, do one, teach one, kill one. And just so you know, I'm not advocating that we kill our patients. I'm arguing that we need to give surgical trainees adequate experience prior to forcing them to do things independently that they've not been trained to do. So going back to how you deal with complications. Intraoperatively, if you're having a complication, that's no time to retreat, rationalize, or ponder, or make excuses. You have to admit your mistake and work towards finding a solution. Putting a finger over a bleeding vessel, suctioning the spillage of spilled intestines, consult appropriate specialists, and I think that this is a key point, acknowledging that there are other people who can help you and you don't have to fix everything yourself. Unfortunately, having complications will lead to feelings of guilt, shame, regret, embarrassment, disappointment, even loss of credibility, identity, and self-worth as a surgeon. But despite that, disclosure to the patient and family is very important. You need to swallow your pride and expose your failures, honesty. I think that humility in these times is sort of the hallmark of an experienced surgeon. You then want to go on to analyze your actions in quality improvement efforts. I think the M&M, or Morbidity and Mortality Conference, is a great forum for this. Complications may occur, but the same complication for the same reason should not. And M&M reinforces this personal responsibility as a weekly ritual when you go up to the podium and take ownership of your patient's complications. I think it also helps to identify systems issues, so those things that, even though not directly your responsibility, are your responsibility as a surgeon in an institution. It also encourages surgeons to be inquisitive and introspective and help identify teachable moments for the trainees and those younger in their practice. I think it's also a good time to seek the advice of colleagues and mentors. What would you have done differently? How would you think about this situation? Reconciliation, or coming to peace with ourselves and continuing to provide quality care to patients, is sort of the next step. And finally, the big takeaway is that you should have improved awareness or vigilance at the same points in future operations. So double check or triple check the orientation of your anatomy before you divide vital structures or before you do an anastomosis where you reconnect them. In surgery, there is a time to go fast, but you need to slow down when you should. Finally, you should forgive yourself, but remember, and as Dr. René LaRouche pointed out, these faces and names will forever be engraved in your memory. I think that despite that, prior should live with us but not hinder us. This is also an opportunity in sort of modern settings to share your hard-earned knowledge and wisdom with your surgical colleagues. So the American College of Surgeons has a social media platform called Communities that allows you to write in a HIPAA-compliant way, and only with people who are members of the American College of Surgeons to have access about your surgical triumphs and your surgical failures, but also your surgical questions to get colleagues' advice. I think finally, it's important not to bury your head in the sand as you're taking care of patients. If a patient's not doing well, then you need to respond. And I think that failure to rescue is every bit as condemnable as the complications that happened in the first place. Dr. Carol Ann Moulton was the senior author of this study that produced this description of a surgeon's emotional reactions phases to adverse events. She's a hepatobiliary surgeon at the University of Toronto, originally from Australia. She talked about the kick, during which feelings of failure emerge, followed by the fall, in which a sense of chaos prevails. But then, hopefully, the recovery when we try to learn from our mistakes, and finally, the long-term impact, which involves integrating what we've learned into our practice. For anyone who's a medical student or a trainee in the room, I think this quote from Dr. Martin Luther King Jr. is apt. Never, never be afraid to do what's right, especially if the well-being of a person or animal is at stake. Society's punishments are small compared to the wounds we inflict on our soul when we look the other way. And to elaborate on this point, Dr. Melanie Sir, along with Peter Angelos and several others from the University of Chicago McLean Center, wrote a paper on young surgeons on speaking up, when and how surgical trainees voice concerns about supervisors' clinical decisions. She draws comparisons to aviation, where crew members are trained to raise concerns about superiors' plans. They interviewed 18 surgical residents about approaches to concerns about supervisors' clinical decisions using a semi-structured guide. They expressed tension between conceding ultimate decision-making authority to the supervisors and prioritizing obligations to patients. A variety of factors, including the department culture, the approachability of the supervisor, the level of knowledge of the trainee, the evidence quality, and the risk of harm, influence their willingness to voice concerns. And most verbalized concerns in a question form, although some expressed their concerns more directly. They concluded that a curriculum addressing strategies to raise concerns appears warranted to optimize patient safety. Dr. Francis Moore was an American surgeon who was the chief surgeon at Peter Bent Brigham Hospital in Boston when, in 1954, a team under his direction with Dr. Joseph Murray performed the first successful human organ transplant, a kidney transplant between identical twins. He was on the cover of Time magazine on May 3rd, 1963 with the quotation, "If they can operate, you're lucky." And I think that that's true. You want a surgical team that faces each error, each mishap straight up, names it, and takes steps to prevent its recurrence. I think that that's good advice. Dr. Max Thorak was a professor of clinical surgery at the Cook County Graduate School of Medicine from 1934 to 1960 and author of Surgical Errors and Safeguards in Surgery. This is in its 5th edition. It was originally published in 1933, and obviously it's an important book. He wrote, "No person is so perfect in knowledge and experience that error in opinion or action is impossible. In the art of surgery, error is more likely to occur than in almost any other line of human endeavor, and it is in this field that it should be most carefully guarded against, since incorrect judgment, improper technique, and a lack of knowledge of surgical safeguards may result in serious handicap for the rest of the life of the patient, or may even result in the sacrifice of that life. For the surgeon, perfection in diagnostic skill is of equal, if not more importance than operative skill." I think that surgery is very much a human endeavor and thus susceptible to the fallibilities of being human and human error. James Reason is probably the most widely known sort of writer on the topic of human error theory, and was a proponent of the Swiss cheese model, in which multiple latent system errors, when combined, lead to downstream adverse events. There are checks in the system to reduce error propagation, such as other members of the operating room team, and that's why teamwork in the operating room is so important, and why things like the surgical safety checklist, which focus on developing a team culture in the OR, have been advocated and have shown good success in reducing errors. So once error occurs, particularly if they're sort of rare or notable, a sentinel event is defined, and it's defined by the Joint Commission as any unanticipated event in a healthcare setting resulting in death or serious physical or psychological injury to a patient or patients not related to the natural course of the patient's illness. Often with central events, what's almost always determined to be the number one root cause is communication errors. And I think that as surgeons in the operating room, you can see how this would happen. If you're working with a resident, you might say, "I meant to cut here, not there," or "I want this instrument, not that one," or forgetting to tell anesthesia, "I just removed the pheochromocytoma, which is why your blood pressure suddenly dropped." This is an example of a root cause analysis for the so-called never event of wrong side surgery, which actually happens much more than it should. It mentions poor MD training and thus marking not followed. So historically, the way that surgeons marked their patients was sometimes via an X. The problem with that was, is it X marks the spot, or X means don't operate here? And as a result of that, knowing that humans are fallible, they developed the universal protocol, and so now instead we put our initials where we're going to operate. So we are entering an era of increasing transparency, which is good, and even focusing on surgeon-specific outcomes. So ProPublica developed the surgeon scorecard, and it evaluates based on one of 8 elective procedures in Medicare: knee replacement, hip replacement, laparoscopic cholecystectomy or gallbladder removal, lumbar spinal fusion, a posterior approach, lumbar spinal fusion, anterior approach, prostate removal, prostate resection, and cervical spine fusion. It's based on Medicare billing data from 2009 to 2013, and they're planning on updating as newer data become available. And it excludes trauma and other high-risk cases. They say that the data was adjusted for age, comorbidities, and the overall performance of each hospital. They also looked at readmission to any hospital within 30 days as a complication. The website reports adjusted complication rates for 16,827 surgeons operating at 3,500 hospitals. And they also will only evaluate a surgeon if the surgeon has performed the operation 20 times or more. So I looked up a surgeon that I trained with, Dr. Larry Jordan, and The reason I picked him is because if I needed my gallbladder out, he's the guy that I would go to. But if you look at ProPublica, it says that he has a medium adjusted complication rate. And that didn't seem right to me. Looking in the literature, I'm not the only one who felt this way. So first of all, this was published in the Annals of Surgery, which is the surgical journal with the highest impact factor, or the hardest to get into. The author list includes Cliff Coe, who's the director of the American College of Surgeons National Surgical Quality Improvement Program, or NSQIP, David Hoyt, who's the executive director of the ACS, and Carl Villamoria, who was the author of the first trial on duty hours in surgery, and also director of Surgical Outcomes and Quality Improvement Center at Northwestern, and the director of the Illinois Surgical Quality Improvement Collaborative. They found that the ProPublica Surgeon Scorecard is the first nationwide multi-specialty public reporting of individual surgeon outcomes, but used a previously undescribed outcome measure and inclusion of only inpatients, and thus questioned it. They looked at ACS NSQIP data from 2012 to 2014 for the 8 ProPublica procedures and for all operations, and the proportion of cases meeting all of ProPublica's inclusion criteria was determined. They assessed the proportion of complications occurring inpatient and thus not considered by ProPublica's measure. And they found that ProPublica's inclusion criteria eliminated 82% of all operations from assessment, and that for all ProPublica operations combined, 84% of complications occurring during inpatient hospitalization were missed. So they concluded that the ProPublica outcome measure correlated poorly with well-established postoperative outcomes as defined by ACS NSQIP. And so the point of me saying this is not that we shouldn't work towards transparency, but we need to have good metrics if we're going to make this information available to the public who are going to utilize that in their decision-making about which surgeon to choose for their operation. Once you have a complication, disclosure is important, but I think that it's something that very rarely is discussed among medical students and surgical trainees in terms of a technique of doing it. The Spikes protocol for breaking bad news was developed originally to tell cancer patients their diagnosis. And it basically had 4 objectives: gather information from the patient and determine their knowledge and expectations, transmit medical information in accordance with patient needs and desires, provide support to reduce the emotional impact and isolation, and elicit the patient's collaboration in developing a strategy or treatment plan for the future. Those who were taught this protocol have reported increased confidence in their ability to disclose unfavorable medical information to patients, and the practice of deception or not disclosing bad news cannot instantly be remedied by a new routine of insensitive truth-telling. Point being, you need to be equipped with the technique of how to do this in the same way we would study how to do an operation. So in addition to the verbal component of actually giving bad news, breaking bad news requires other skills, which is not surprising. Responding to patients' emotional reactions and even anticipating them, involving the patient in future decision-making, dealing with the stress created by the patient's expectations for cure, involving multiple family members, and this is sort of an art in and of itself. When you're initially disclosing bad news, you want to control how many people are in the room, but later you want to make sure that everyone has the same information and is on the same page. The dilemma of how to give hope when the situation is bleak may also describe the mum effect, when the bearer of the bad news, in this case the surgeon, is reluctant to deliver the bad news because of the anxiety, the burden of responsibility for the news, and the fear of a negative evaluation. So this shows that 55% of people who took a survey after learning about the Spikes protocol thought that being honest but not taking away hope was the most difficult part of discussing bad news. It also shows that the Spikes protocol made sense to 94%, that having a strategy or approach to breaking bad news would be helpful in practice to 88%, and that 95% thought Spikes is practical and can be used in clinical practice. So Spikes, in the article, goes through different statements that you can make to patients. First, empathic statements such as, "I can see how upsetting this is to you," or "I can tell you weren't expecting to hear this." One that they recommended that I don't really agree with is, this is very difficult for me also. And the reason I disagree is because you shouldn't be focusing on yourself when this is probably the worst news that they've heard in their life. It also suggests open-ended exploratory questions. How do you mean? Tell me more. Could you explain what you mean? And finally, validating responses to make them aware that you're listening and you're recognizing their emotions. I can understand how you felt that way. I guess anyone might have the same reaction. SPIKES is actually an acronym. So S stands for setting, and part of that is mental rehearsal, trying to review your plan for telling the patient and anticipating their responses to emotional reactions to difficult questions. You should arrange for privacy. You should give your beeper to someone else if possible. You should sit down so that it shows that you are going to spend your time with them. P stands for patient's perception. Before you tell, ask, using the open-ended questions that I discussed. And for instance, what have you been told about your medical situation so far? It gives you the opportunity to correct misinformation and also assess where the patient is at in understanding their disease. And it also allows you to identify any denial or wishful thinking or unrealistic expectations and reorient. I is for invitation. While most patients want to know their diagnosis and prognosis, some don't. And so you can say, how would you like me to give the information about the test results? Do you want all of it? Do you want me to talk to a family member? K is for knowledge, and here you're basically giving them a trigger warning. Unfortunately, I've got some bad news to tell you. You need to avoid medical jargon that they're not going to understand, and avoid excessive bluntness, which I think, unfortunately, surgeons are prone to. You need to give information in small chunks and check periodically for understanding. This is also something where giving the information not on just one occasion, but on repeat occasions is helpful. Sometimes if you say the word cancer, people won't hear anything you say after. In the same way that if you say there's been a complication, they might not be able to process information. E is for exploring or empathy. Emotional reactions can vary from silence to disbelief, crying, denial, anger. You need to observe the emotion, identify it, identify the reason for it, acknowledge it, and express empathy. Finally, S is for strategy or summary, and physicians feel uncomfortable because they're uncertain about patient expectations, fear destroying hope, and fear their own inadequacy in the face of uncontrollable disease. But you still need to come up with a plan moving forward. I'm sorry laws this is a web page that states that there's 36 states which have apology laws, which prohibit certain statements, expressions, or other evidence related to disclosures from being admissible in a lawsuit. Fortunately, Michigan is one of those 36 states, although where I'm currently in fellowship in Illinois and where I'll be practicing next year in New York are not. When I gave this talk to Peter Angelos for his feedback, he said, it's also important to say, I'm sorry that this happened to you, or I'm sorry that this is the case, without immediately saying, I'm sorry that I caused this complication, and waiting until you sort of know all of the facts before taking that next step. Finally, after having complications, it can be very difficult for surgeons to see their patient. It's a constant reminder of what went wrong. But although seeing the patient who had a complication is uncomfortable, it's imperative that you continue to do so, and preferably more than you did or would if everything had gone well. You need to provide reassurance, clarify the plan going forward, including how the complication will be addressed, and let the patient and family know of any changes in protocol that resulted from analyzing the complication to prevent this from happening to patients in the future. I think that last point actually is something that we overlook, that patients do care about future patients avoiding the same thing, and they want to know that you're taking steps to try to avoid that. I think this talk hinges a lot on sort of balancing opposing options, hope versus realism, the detachment that you might need to move on after complications with the compassion that you want in your surgeon. And as a result of that, I'm going to talk a little bit about sort of futility in my final minutes. The Hastings Center is a bioethics think tank in New York and published among the first ethics-based guidelines on the termination of life-sustaining treatment in the care of the dying back in 1987. Despite our best efforts and the impressive expansion of capabilities in medicine and pharmaceutical technology. Sometimes patients have terminal conditions. Sometimes clinicians and surgeons feel that further aggressive treatments would be futile. So this is a slide of different definitions of futility. It comes from the Latin futilis, meaning that which easily melts or pours. The Oxford English Dictionary defines it as leaky, vain, failing of the desired end through intrinsic defect. Schneiderman wrote that effective treatments, if not beneficial, may still be futile. The treatment must help achieve a goal of care, such as regaining function, improving quality of life, prolonging life, or palliating a symptom. Physiologic futility was described by Tomlinson and Brody as a treatment that cannot be expected to provide any medical benefits to the patient and should not be offered. Quantitative futility is synonymous with physiologic futility, but also relies on sort of a percentage likelihood. And different people would define this threshold at varying levels, 1 in 100, 1 in 1,000. Qualitative futility is perhaps the most contentious because it's been impossible to identify universally held beliefs about what will be an unacceptable quality of life. And finally, imminent demise futility is an intervention in a patient who can be expected to die prior to hospital discharge. The often unstated goal of defining futility is to permit a physician to use it as justification to unilaterally withhold or withdraw treatment, even over the objections of a competent patient. Saying futility is a power grab by physicians to resurrect paternalistic authority from the pendulum swing toward patient autonomy, since it limits the patient or surrogate from future medical decision-making. In terms of futility, sometimes it creates an adversarial relationship between patients or their surrogates and the surgeon. The patient autonomy permits choice or refusal based on respect for autonomy and informed consent. Physician autonomy means that patients do not have the right to any treatment they choose because this might force a physician to provide treatment he or she does not believe is appropriate, thus violating the physician's conscience. There are a variety of mechanisms for resolving futility disputes, developing community and/or institutional or hospital standards that define criteria for futility and establish a process. And one example of this was the Houston Policy for Medical Futility, which was developed after convening an ad hoc group of the Houston Bioethics Network in August of 1993 called the Houston Citywide Task Force on Medical Futility. This was later supplanted by the Texas Advanced Directives Act of 1999. And their policy is that patients or surrogates are given 48 hours or more advance notice prior to a meeting of this committee. The physicians must try to transfer the patient to another physician or institution, but that if the committee agrees requested treatment is inappropriate and no accepting physician or institution is found after 10 days, the physician and institution are not obligated to provide life-sustaining treatment. However, there is a possibility of a court-ordered extension, but only if they think that another physician or institution that would accept the patient would be found. Empiric data since this law came out show that only a minority of Texas hospitals have used the law, and most cases still were resolved before the 10-day waiting period. The American Medical Association Council on Ethical and Judicial Affairs suggests a procedural due process approach. And they start with patients, proxies, and doctors deliberating and negotiating what constitutes futile treatment versus acceptable therapy. And it's sort of best to do this early on. Then suggest shared decision-making, then involving a consultant or patient representative to facilitate discussions. Next, the institutional committee, such as the ethics committee. Then, depending on the results of that committee's process, trying to transfer the patient to another physician if the institutional process thought that the patient was right in terms of seeking additional treatment, or transferring to another institution if the institutional process said that maybe this is quote-unquote futile. And finally, if no accepting physician or institution is identified, perhaps because the requested treatment falls outside of medical norms, the intervention need not be provided, although they acknowledge that there might be legal ramifications for this. Discussing goals of care is better at the outset of the surgeon-patient relationship than after complications occur and the patient's health is in a rapid downward spiral. And I think that physicians know the data from their experience with the effectiveness of their proposed treatments and complications and side effects, whereas patients know their life goals and goals of care and what burdens of treatment they're willing to endure. Shared decision-making thus kind of unites those aspects that each brings to the table, and I think that communicating and honestly disclosing prognosis and your best medical advice goes a long way. Focusing on working towards goals of care, and in the context of a patient who might need surgery at the end of life and has a DNR or do not resuscitate order, the surgical ethics standard is still required reconsideration as opposed to automatic suspension of the DNR order, where you, again, sort of discuss how in the perioperative period, the likelihood of successful resuscitation is much higher, but still coming to some agreement with the patient. Finally, there are a variety of consultants that can be helpful in these situations. Having a second physician in the same specialty, that way you have a fresh set of eyes and also a different perspective on possible interventions. The ethics consultants or committee, palliative care. There's such a thing as checklists of triggers for a palliative consult, such as being in the ICU for a month or certain conditions. Social workers, pastoral care or chaplains, and then patient advocates and representatives. I think that there's a spectrum of choices. So on one end, we often are trying to, if we think things are futile, push patients towards do not resuscitate and/or hospice, palliative care, comfort-only care. But there's no escalation of care, and there's also these other sort of sub-steps that you can take on the way to just comfort care only. So I want to wrap up with enough time for questions, and so I think that I'll put this slide up at the end, but just quickly acknowledge Peter Angelos, who's my mentor in both endocrine surgery and surgical ethics, Amy Lynn, who helped coordinate my visit here, Parth Modi and Eric Singer, who I wrote my book chapter and article on futility, Andy Schumann and Christian Verclair, who I'm sure you all know, and then Mark Siegler, who's the director of the McLean Bioethics Center and also the Center for Bioethics and Social Sciences in Medicine at the University of Michigan. Thank you. I'd be happy to take questions if we have time. Go ahead.
Can you comment on the prevalence of advertising of surgical procedures, particularly at outpatient clinics, vis-a-vis ethical considerations?
I missed the word appetizing of? Advertising of surgical procedures. I think that falls a little bit outside of the scope of my talk, and the American Medical Association does have guidelines on what is appropriate and inappropriate advertising. And there's also been some case law about that, obviously stating that you can't exaggerate your credentials or your outcomes. I think that we're in an era where hospitals are competing with each other, and so they're trying to advocate the services that they have. You know, you see a lot of ads that, you know, this hospital recently purchased a surgical robot and you can have the latest minimally invasive approach here. And I think that as long as you have people who are experienced, again, if you're not overstating your experience or your outcomes, then it's reasonable, although I think that it is a little departure from historically, I think, what we've done in medicine. To sort of let our experience among our colleagues and among patients themselves speak for itself. Go ahead.
Can you speak to the surgical assessment for the complications of the surgery and your informed consent process or recommendations about informed consent process?
Yeah, so informed consent is definitely one of my sort of favorite topics. I think that, you know, we always tell surgeons that you need to discuss the risk, benefits, and alternatives, but we don't really teach them what those are, and often kind of throw trainees in to just consent the patient. I think that tools like the NISQIP surgical risk calculator are a starting point, particularly for patients that you think are very high risk, that your experience or your sort of gestalt of the patient say this patient's likely to experience complications. And I think that you can, there's even an article in the Bulletin of the American College of Surgeons about utilizing the risk calculator in talking with patients. I think that that's also sort of an art that needs to be developed. The American College of Surgeons also has patient education brochures for very common procedures like appendectomy, cholecystectomy, inguinal hernia, ventral hernia, colonoscopy. And I think that those are a nice resource for patients and also provide data from ACS NISQIP on the likelihood of complications.
They have enough written tests that it's probably enough.
Well, again, thank you.
That was excellent.
Oh, hi, thanks.
My name is Maureen.
Nice to meet you.
I'm part of the ethics committee. Long time ICU nurse.
Oh, okay.
My former life, now palliative care, which is probably, a natural transition, right?
Yeah, no, there's a lot of palliative care over there.
Thank you for bringing up that thing about abandonment, because I think that in my 20 years in the ICU, that's what I think I saw the most. And my question for you was, in surgical